Welcome to the Cohen Veterans Bioscience webinar series. This is a monthly program sponsored by Cohen Veterans Bioscience for the brain research and systems biology communities. Cohen Veterans Bioscience is a nonprofit research alliance whose mission is to transform research in veterans' mental health through translational research. We are focused on understanding the molecular underpinnings of diseases such as PTSD and TBI to develop better treatments and diagnostics. Before I introduce today's speaker, let me walk you through some logistics. This program is being recorded and will be archived in the Cohen Veterans Bioscience YouTube channel and website. The presentation will be approximately 45 minutes to allow for Q&A afterwards. Please use the Q&A feature on the website to post a question, and we will pose the question to the presenter. Today, our speaker is Dr. James Stone. Dr. Stone is Associate Professor and Vice Chair of Research in the Department of Radiology and Medical Imaging at the University of Virginia. He is also a founding member of the American College of Radiology Head Injury Institute. He is a clinical interventional radiologist with a neuroscience background. His laboratory currently explores questions related to improving the clinical diagnosis of traumatic brain injury in both preclinical models and human subjects. Additionally, Dr. Stone is involved with efforts to build a normative library to support improved population-level research and to work towards single-subject assessment of patients with TBI. He is additionally involved with work utilizing machine learning, deep learning approaches for the automated segmentation of imaging findings, diagnostic of TBI. Further, he is a member of the Neuroimaging Core Laboratory for the Chronic Effects of Neurotrauma Consortium. It is my pleasure to introduce Dr. Stone, who will speak on establishing a normative neuroimaging library to support traumatic brain injury diagnosis and treatment. Dr. Stone.
Thanks very much for that introduction, and I'm thrilled to have the opportunity to be able to spend some time here over the next 45 minutes or so talking a little bit about normative neuroimaging, why it's important for where the field of neuroimaging presently is, and how it can facilitate current clinical diagnostic approaches and also help to facilitate evolving approaches as well. So normative data, by its definition, is basically data from a reference population that establishes a baseline distribution for a core measurement against which the score or measurement can be compared. It's typically obtained from a large, randomly selected representative sample from the wider population. So this is sort of a general definition of normative data. Now, normative data for neuroimaging is essentially a reference set of values across an entire three-dimensional volume of a brain that is specific to the imaging approach that is being used or the imaging sequence that's being used. Now, in order to provide a little bit of context for why normative data is important and how it's a critical piece of information that's necessary as the field continues to evolve, I'd like to take a few minutes and just provide a little bit of a history of the field of neuroimaging and the evolution of the approaches that have basically gotten us to this point. So neuroimaging as a field has been around for about 100 years, and the first report of neuroimaging was back in 1918, 1919, and it was essentially a air encephalogram that was performed by Dr. Walter Dandy. This essentially involved introducing air into the CSF space, allowing that air to rise into the ventricles and then performing a standard X-ray in order to be able to see the morphology of the ventricles. As you can imagine, this wasn't a particularly well-tolerated exam, but this was really the first foray into neuroimaging with the new availability of X-ray imaging at that time. Now, the next big innovation at that time for neuroimaging was cerebral arteriography. And so the first cerebral arteriogram was performed by Dr. Moniz back in 1927. And it essentially involved a direct access of the carotid artery and the introduction of substances into the carotid artery that would cause these vessels to become opaque to imaging. Now, Dr. Moniz did a series of 9 patients back in 1927, injected a number of different substances, some of which were actually quite caustic and resulted in some fairly dramatic responses and adverse responses in those patients at that time. But this ultimately ended up leading to cerebral arteriography, which has been an extremely valuable diagnostic approach, and has also paved the way for a variety of different endovascular interventional approaches over the years as well. Now, back in 1961, Dr. William Oldendorf developed the theoretical basis for computed tomography, and this was really a quantum leap for neuroimaging at that time, and allowed for neuroimaging to basically emerge from planar X-ray based imaging and evolve into an area where we were started to be able to actually see the brain as a 3-dimensional volume, and to understand the structures that were contained within the brain, and to see how those structures may change in the state of normal or disease. And Dr. Hounsfield applied this methodology for clinical diagnosis in the early 1970s and ultimately received a Nobel Prize for the work. Now, in the 1980s, CT was further evolved with the application of spiral techniques, whereby there was continuous imaging of the patient as they moved through the tube. In the 1990s, multi-detector CT was introduced, and these two innovations really allowed for CT to evolve into a modality that provided fairly high-resolution structural information about the brain, either without contrast or with the administration of contrast. Now, in the 1970s, another major innovation that was extremely important and continues to be extremely important for neuroimaging was the introduction of MRI. And so Dr. Latimer published the first images, spatially differentiated MR images at that time, and Dr. Damadian published the first clinical approach using MRI for tumor detection. And MRI essentially relies largely upon understanding the behavior of water in tissues by aligning water molecules and then basically disturbing those aligned water molecules with a series of different RF pulses. And the periodicity and the number of RF pulses and the intensity of RF pulses that are introduced to those aligned water molecules allow for us to be able to explore the physiology and anatomy of tissues in a variety of different ways. And so these different sequences, as they're called, allow us to be able to look at tissues that may be weighted more towards the visualization of fat or proteins, tissues that may be weighted more towards the visualization of fluid and fluid-surrounded structures, suppression of fluid, or the magnification of artifacts that may be caused by deoxygenated hemoglobin or others, in order to be able to provide a window into the oxygen state of hemoglobin within the brain, or to provide a window into the presence of microbleeds. Now, in parallel with the evolution of CT and MR, other techniques emerged as well, such as transcranial Doppler, that allows for the visualization of the velocity and also waveform of blood moving through the cerebral vasculature, as well as a variety of different radioisotope-based approaches that allows for the injection of biologically active radiopharmaceuticals that will provide physiologic and anatomic and molecular information about what's occurring within the brain. Now, all of these techniques have basically fit into a general neuroimaging clinical workflow. And this is basically a set of procedures and workflows that exist within a hospital in order to allow for this information to be incorporated into the management of an individual patient. And the very basic steps in this clinical workflow essentially involve imaging acquisition, after which the imaging will be presented to a radiologist or a neuroradiologist that has received training in order to be able to detect patterns that are consistent with disease. And then that neuroradiologist will basically end up generating a descriptive report that largely contains a qualitative interpretation of the information that these techniques provide in terms of understanding whether there is disease present, whether the scan represents a normal scan, and if there is disease present, what the most likely pathology may be to explain the findings. So this, again, is essentially the current present-day paradigm for the way that really all imaging and neuroimaging as well is managed in the hospital setting. And this is basically an example of the type of report that a neuroradiologist may generate for the interpretation of imaging. And so, basically we'll describe what the history of the patient may be. We'll describe what the actual imaging technique was that was performed in order to be able to acquire the information that was being interpreted. And then it will essentially end up providing a summary of the findings that may be incidental findings, it may be benign findings, or it may be findings that are concerning for a particular disease process. And then an impression that ends up, essentially providing a summary of those findings and any recommendation for next steps based upon those findings. So let's talk a little bit about how this works in the setting of traumatic brain injury. So when you have a patient that presents to either an outpatient setting or presents to a hospital setting or a clinic, there's a standard approach for assessing that patient. Now, there may be heterogeneity from one practice to another in exactly how these approaches are applied, but the general approach to a TBI patient is to acquire a history in order to be able to understand what the actual trauma was, what the mechanism of the trauma may have been, whether the patient experienced any loss of consciousness, whether they were amnestic to the event at all. Then a physical exam is performed in order that has a focus upon an expanded neurological exam to see if there are any neurological deficits on exam. Neuroimaging may be performed if there's a high clinical suspicion for a type of injury that may manifest on the neuroimaging that we presently have available to us. And if indicated, neuropsychological testing may be performed as well. Now, CT is really a first-line imaging tool for traumatic brain injury, particularly in the multi-trauma patient. It's often acquired as a part of a routine full-body trauma workup, and it's really most useful for ruling out intracranial hemorrhage and guiding the types of decision making that may require urgent neurosurgical intervention. Because of the ionizing radiation that's involved in CT, and because of the value of CT being more towards sort of guiding surgical intervention, there is an entire decision-making process that will go into determining whether or not to actually acquire a CT in the setting of trauma. But again, CT tends to be most useful for urgent decision-making. And these are the kinds of things that we might see with a CT. So the image on the left is an epidural hematoma with a significant mass effect on the brain. The image on the right is a subdural hematoma that involves basically a large component of the subdural space along the right convexity. And you can see that there's midline shift. There's basically movement, mass effect from that subdural hematoma that's moving the ventricle and also the midline structures to the other side of the brain. We may see traumatic subarachnoid hemorrhage, and so bleeding into these spaces into the subarachnoid space. And the image on the left basically shows the area more towards the base of the brain, and that bright material is basically blood that's picked up on CT. We may also see petechial hemorrhage or larger hemorrhage as well, and oftentimes this petechial hemorrhage is indicative of significant injury to the axons, what's known as diffuse axonal injury. And we may see cerebral edema as well, which is basically the accumulation of fluid within the brain, whether within cells or outside of cells, but resulting in essentially diffuse swelling of the brain, compaction mass effect on the ventricles, and in the worst cases, herniation of the brainstem, which has a very high mortality rate. So magnetic resonance imaging really is a second-line imaging tool. It's typically employed when there's discordance between symptoms and CT finding, and it's used because routine MRI tends to be more sensitive to subtle anatomical findings than CT. And these are the kinds of things that we may see with an MRI when we perform neuroimaging. So the sequence on the left is what's known as a susceptibility weighted imaging sequence, and this is an approach that is really largely geared towards looking at deoxygenated hemoglobin within the brain. It allows us to be able to see microbleeds with fairly high resolution and fairly high sensitivity. The image on the right is a fluid attenuated inversion recovery sequence, also known as FLAIR, and this basically shows a bright area over to the right side of the brain that is likely consistent with glial scarring. Now, when we look at the most sensitive sequences that we have available in clinical neuroimaging for qualitative interpretation, and we look at the area between the lesions that we're able to actually detect, there's a whole lot that's going on under the surface. And so there are a variety of different stains that have been developed over the years that can be applied to tissues that allow us to be able to detect injury to white matter, so axonal injury, allow us to be able to detect injury to glial cells, so some of the supporting cells within the brain, and allow us to be able to look at neuronal injury as well. And so again, when we sort of look at the spaces between these large lesions within the brain that essentially look normal on imaging, we can see that there's a whole lot going on microscopically and molecularly that may contribute to a patient's symptoms. So, basically, when we sort of consider the clinical imaging sequences that we have available and the challenge of really understanding how the networks within the brain are altered and how some of the local and sort of broader scale physiological dynamics are involved, it's essentially equivalent to try and understand what's going on at the street level by this type of sort of 30,000 foot image. So when we consider the role of neuroimaging in the setting of traumatic brain injury, neuroimaging is really confined to having utility. Current clinical neuroimaging is confined to having utility with moderate to severe traumatic brain injury. And so moderate to severe TBI really by their very definition have findings that are present on routine clinical neuroimaging. Whereas mild TBI and concussion, there really is relatively little role for neuroimaging. And neuroimaging is, at least using our current clinical approaches, is largely negative in those circumstances. The only exception to that is mild complicated TBI, where there may be milder symptoms, but there are positive findings. But the vast majority of mild TBI and concussion have essentially negative findings. And when we consider the incidence by severity of traumatic brain injury, this is the vast majority of patients who sustain a traumatic brain injury, where current clinical imaging approaches have little to no role in providing care providers the information that they need in order to be able to make management decisions for these patients. So it's very important for there to be an evolution of current neuroimaging approaches in order to be able to allow for neuroimaging to have a larger role in helping to manage the patient with mild TBI and concussion, so we can have a better understanding for which patients are going to improve on their own over time, which patients may have more long-lasting deficits, and which patients may need rehabilitation or another intervention in order to be able to correct a natural course that may result in prolonged symptoms. So when we consider the evolution of neuroimaging towards the present day and all of the innovations that we talked about a little bit early in the talk, we are basically on the verge of a paradigm shift between a historic model that has evolved towards better and better acquisition techniques within the context of a neuroradiologist that will provide a qualitative interpretation of that information, and into an era where there will be more and more utilization of advanced analytical approaches in order to be able to help neuroradiologists and care providers with maximally mining the information that is available on current neuroimaging approaches, and also allowing for advanced neuroimaging approaches that have previously been basically held within research to be able to bridge the gap between research and be able to actually make their way into the clinical area, to be able to really significantly expand our ability to be able to detect injury in these patients who have mild TBI or concussion. So what is quantitative neuroimaging? So quantitative neuroimaging is basically the process of taking neuroimaging information, taking three-dimensional or four-dimensional neuroimaging information, and processing that information in a way that we're able to start to actually acquire quantitative numerical information that can be assessed at a variety of different orders and a variety of different levels. And this quantitative information contains data that can basically be mined in order to be able to have a more precise estimation of diagnosis, a better understanding for prognosis. And by using the information that is available through this more powerful and more objective mining of information that may be tied to a priori information on correlations between a variety of different clinical variables, we may be in a position to actually guide therapy. So I want to step through a couple of different cases for how quantitative neuroimaging is currently being utilized in order to be able to get more information from current routine clinical sequences and to start to begin to move some of these advanced neuroimaging sequences that have been confined to the research realm into the clinic. And so one of the approaches that has been around for a little while now is the ability to be able to quantitatively interrogate the gray matter within the brain. And so cortical measures have been used for a number of different years now, and the basic approach to acquiring quantitative information on cortical measures involves taking an anatomical MRI of the brain, and essentially inputting the anatomical MRI into a model that allows for the removal of the tissue around the brain, including the skull around the brain as well. And then it includes a number of different a priori models that allows for us to be able to segment out the CSF from the gray matter, from the white matter, and the deep gray matter as well. And by taking that segmented gray matter, we're then able to basically provide a numerical interrogation of the information that is available on that extracted gray matter in order to come up with estimations of cortical thickness and cortical density as well. And we're able to take those cortical thickness and cortical density measures and further refine them into regions of interest that may have a specific functional component, whether it be motor, sensory, or association, or otherwise associated with them, and to understand how, in the individual patient, how their cortex is, what the numerical values are that are associated with the cortex. Now, the first approach to actually make its way into clinical care was approved by the FDA back in 2006. And so NeuroQuant is a medical imaging processing software package that was approved back in 2006 and allows for the ability to be able to provide estimations of some of these cortical measures. Just last year, there was another package that was approved by the FDA called NeuroReader that also looks at cortical measures as well. And this is the basic report that's generated for clinical locations that are currently using these packages. And so this is a NeuroQuant patient report, and you can see that there are a couple of different ROIs that are being interrogated for cortical values. So again, the images here you see on the screen, the anatomical images, you see that are color-coded. These different color codes represent specific ROIs, and then the boxes that are down here at the bottom represent the numerical value that's associated with the mean of the quantitative intensity values that are within those ROIs, and how this single data point compares to a normative sample for this particular imaging sequence. And so this is very much of an evolving science here in terms of sort of understanding how these data points represent disease when they're sort of compared to 95% of the remainder of the normative population. But this is the kind of information that is beginning to make its way out into the clinical setting that allows for the availability of these more precise quantitative measures. So as was illustrated in the previous readout, normative data is very important for these types of tools to work. Without normative data, essentially these quantitative measures are, essentially data points with no context. And so this is really one of the most pervasive, currently clinically pervasive use cases for why it is that high quality normative data is extremely important. Now I want to talk a little bit about quantitative analysis of advanced imaging. So although the current use of medical imaging for traumatic brain injury is largely confined to these types of examples where there are macroscopic very significant changes that are occurring within the brain that are visible at the scale of basically the naked eye, where the ability to be able to actually see these lesions directly. There are a variety of different sequences that have emerged over recent years that allow us to be able to see things on a much more subtle level. And so we know from a number of different previous studies that there are things that occur at a microscopic level following traumatic brain injury, including the degeneration over time and disconnection of axons and white matter in general, neuronal death, glial injury. We know that there are things that are occurring on a molecular level, such as the activation of cascades that are involved in apoptosis, changes that are involved in necrosis as well, and a variety of different inflammatory mechanisms and free radical-based mechanisms as well. So there are just a broad scale of things that have been identified from a number of different basic science and translational studies. But there has essentially been a gap between what our clinical imaging tools have been able to identify and what we actually know is occurring within the brain. But again, some of these advanced imaging methodologies are allowing us to be able to see and characterize things that are occurring within brains on a microstructural and physiological level, as well as a molecular imaging level as well. So one of the most widely used measures for gaining an understanding of things that are occurring on a microstructural level within the brains of individuals who have received a traumatic brain injury are measures that allow us to be able to look at diffusion within the brain. And so diffusion weighted imaging at its most fundamental level allows us to be able to see how water molecules move or diffuse along a vector within the brain. So by looking at this diffusion along a number of different vectors, we're able to actually get a sense for not only the magnitude of diffusion, but also the directionality, the shape of that diffusion as well. And we're able to boil it down into a number of representative values that are referred to as the diffusion tensor. And so the diffusion tensor give us not only the directionality of diffusion, but they also give us the shape of diffusion as well. This is important in the white matter because white matter basically is very ordered, and it also is largely surrounded by myelin, which is a fat-based structure that is very resistant to water crossing the bundles of these structures. And so within white matter, there is a very ordered diffusion of water that tends to resemble much more of an ellipse than what the natural behavior of water diffusion is, which is much more of a spherical shape of diffusion. So in the traumatized brain, we know that there's injury to the white matter, both through axonal disconnection and also through direct permeabilization of axons as well. And this normal shape of diffusion will actually become more spherical in nature. So using diffusion tensor imaging, we're actually able to visualize this and to characterize this shape of diffusion and to represent it along a three-dimensional map with higher intensity values being representative of more anisotropic or more elliptical diffusion, and darker areas being reflective of more isotropic diffusion. And we're able to build tracts out of this information, or just directly mine the numerical information at the level of a voxel or an ROI. So another approach that's been extremely useful are measures that rely upon being able to image the oxygenation state of hemoglobin. So hemoglobin becomes very highly paramagnetic when it is deoxygenated, and we're able to image the difference between this paramagnetic hemoglobin and when it's deoxygenated, and the diamagnetic hemoglobin when it contains oxygen. We're able to capitalize upon this imaging property in order to be able to infer neuronal activity. So the brain has a very powerful mechanism of being able to very rapidly shunt oxygenated blood to areas of activity. And by visualizing that oxygenated blood, there are inferences that can be made as to the dynamic activity of the brain. This has been used for functional MRI measures. It's also been used in order to perform what's known as functional connectivity, which is essentially looking at the changing oxygenation state of blood in 3 dimensions over time, and applying a variety of different metrics in order to be able to look at the separation and timing between one area of the brain and another in order to determine the connectivity of remote areas from the brain, and to then generate these connectivity maps that can provide insight into the connectivity of the brain at baseline, or it can provide insight into the changing connectivity of the brain in disease states. Another approach that is both used clinically and also can be used in a more advanced way as well is perfusion-weighted imaging. And this basically involves either injection of contrast and watching that contrast load move through the brain to understand the way in which blood moves through the brain, both the volume of flow and also sort of the perfusion at more of a capillary level. So this has been is an approach that's currently used clinically, but again, there's sort of a wealth of information that is available for mining for more advanced measures. So another way that quantitative imaging is currently being used is, and this is really a very dynamic, I would say probably one of the most dynamic areas right now as it relates to quantitative neuroimaging, is the use of very sophisticated decision trees in order to perform lesion classification. So the various terms that have been applied to this are random forest decision trees, machine learning, deep learning. Some may also sort of apply kind of artificial intelligence and other labels to this as well. But the very basic idea behind this is that by teaching an algorithm on what the features are of a specific lesion within the brain, so by training an algorithm and allowing for a classification scheme or a very highly ordered decision tree to be created around the identification of that lesion, you can show an algorithm basically a brain that it's never seen before, and it will be able to identify that lesion without further prompting. And so you may allow for train an algorithm to recognize an epidural hematoma. You may train an algorithm to recognize areas within the brain that are more representative of microbleeds, white matter hyperintensities, or other lesions. And so, again, this approach really sort of relies upon this ordered decision tree that asks the most important questions at its top level, and then as it drills further and further down, there's just a refinement upon these initial very important questions in order to arrive at a conclusion when the algorithm runs through to the very bottom. Now, this is a very extremely oversimplified example of how a decision tree may work. But if you are interested in identifying a ball and the type of ball that you're working with, you may design a random forest decision tree that first asks, what shape is it? Is it spherical? The second question you may ask along a decision tree is, what color is this spherical object? And then the third question you may ask is, what pattern is associated with the spherical object? And you may come to the conclusion that it's a basketball. If it's not an orange color, you may ask if it's white. You may then ask again what the pattern is and arrive at the conclusion that it's a baseball. Or thirdly, following down through this decision tree that you've established, you may come to the conclusion that it's a tennis ball. And again, the features that we would fit into our random forest decision tree are shape, color, pattern, and then we would presumably arrive at a conclusion based upon that decision tree. So this is actually the same general approach that's currently being used in the design of really the engines that drive automated vehicles. And so automated vehicles will look at their environment, and then based upon their environment, they will classify the images and the objects that are in front of them in order to be able to understand where there may be lanes on the road, where there may be automobiles, and where there may be basically other objects on the road. And then they'll basically sort of assign vectors to these objects as well, and we'll be making dynamic decision process on the fly based upon very rapidly running through these multi-layered decision trees in making decisions about how to interact with the environment. Now, we can do this with imaging as well. And so instead of asking questions that may be relevant to identifying things within the environment, we may ask questions that are relevant to understanding the features that may help to identify a tumor focus, for example. And so we'll be calculating basically probabilities of areas, voxels that represent white matter, CSF, gray matter, and may represent areas of tumor or areas of edema as well. And again, this is all driven by asking questions around features. And so the available features really are infinite, but the kinds of features that we may be looking at might be the mean of a T1 weighted image, the variance of an image on flare, or the texture map of a T2 weighted image. And by understanding the precise characteristics across these various ways of looking at imaging, then we're basically able to essentially classify lesions or classify pathologic phenomena in imaging. So this is a real-world example here of tumor imaging from a grand challenge that our group basically participated in a couple of years ago. And this basically ended up identifying this decision tree that was based upon these features that had higher and higher weighting, higher weighting going from the top down to the bottom of these various features. And so with a very high degree of consistency and reproducibility, we were able to design a random forest decision tree that allowed for the detection of tumor and also allowed for the detection of associated edema as well. So more recently, we worked on a random forest approach for detecting white matter hyperintensities. And so again, by going through this approach of manually segmenting the lesions of interest and then trying to understand what the features were that were representative of these lesions of interest, we were able to basically come up with a weighted set of features that can basically comprised our decision tree and then go through a variety of different stages to create this automated approach. So for all of these things that we've been talking about here over the last 40 minutes or so for quantitative imaging, normative neuroimaging data is extremely important. So normative neuroimaging data is the canvas upon which we can basically lay all of these individual findings. So whether it's large-scale injury or disease data, or whether it's smaller scale information, it's extremely important for us to understand what normal is, because normal can vary around the population based upon a variety of different measures. With large-scale normative neuroimaging data, we're able to basically perform this comparison between the two at a quantitative numerical level to come up with a repertoire of diagnostic and prognostic features. And it's this repertoire of diagnostic and prognostic features that provide not only powerful analytics for research, but they really feed into the next generation of patient care platforms that will be based upon machine learning and deep learning engines. And so although we currently have available platforms that allow us to be able to perform volumetrics and perform other assessments of clinically available sequences, this next generation of platforms will allow us to be able to do much more sophisticated interrogation for biomarkers that may be predictive of a current disease state or recovery from that disease state. And so normative data, although many of our laboratory tests, such as an hematocrit or other blood tests or even blood pressure and other physiological measures, we have a pretty good understanding for the distribution of those normal values within a population. That really is less so for imaging, and there really is a quite information, population-based information for what neuroimaging is supposed to look like quantitatively across the population, and how these values may vary based upon a number of different values. So in terms of understanding normal, images like this are fairly straightforward. And so this is fairly black and white. When we start moving into cortical measures, or when we start moving into more microanatomical measures or functional connectivity measures, again, the normative information at a quantitative level becomes extremely important. And so the American College of Radiology actually looked at this issue back in 2014. And so there was a summit that was held in Montreal in 2014 in order to examine some of the best practices for building normative databases for neuroimaging. At that time, it was attended by 55 experts in the field, and the state of the science was reviewed, and there were recommendations that were made for building high-quality normative data. Now, one of the important components that emerged from this consensus opinions that emerged from this meeting was that really most normal data currently exists as matched controls for research, and they're recruited for their similarity to experimental populations and questions. Now, it was also recognized by the group that existing normal neuroimaging data that may exist in other databases, it really is sort of lacking when it comes to scanner harmonization, rigor of subject screening, and inclusion of standard sequences for advanced imaging. Now, the kinds of things that were also recognized in this meeting that may affect and may introduce variability across the population into normal were things such as age, gender, race or ethnicity, handedness, socioeconomic status, IQ or cognition, psychological health or psychiatric disorders, including substance use, and general medical history as well. Other things that were recognized as more obvious causes were neurological disorders, such as seizure disorders, dementia, stroke, or MS, and cardiopulmonary disorders were recognized as having an influence as well, particularly with respect to atherosclerosis or general cardiovascular disease. It was also recognized that obesity may also have an influence on neuroimaging as well. So there were a number of recommendations that emerged from this meeting in terms of best practices for creating normative data. The first one was really collection of demographic information in order to account for normal variation and to understand the factors that may influence normal variation. The second was an acquisition of the medical history, so a targeted query for significant pre-existing medical problems which could challenge the interpretation of results. And then the third was to really perform standardized cognitive assessments in order to be able to have additional correlative information for individuals that may be included into a normative database. Another extremely important recommendation that emerged from this meeting was the importance of harmonization approaches. The importance that sites are using standard sequences and that those sequences are aligned, that there are measures that are taken to account for vendor-related differences, understanding that there are significant obstacles that currently exist in comparing one vendor to another, both in terms of software and also hardware as well. The importance of frequent acquisitions of phantom data, both from in vitro and also in vivo models, in order to be able to account for some of these hardware and software differences. And then the importance to utilize and to continue to evolve post-acquisition techniques that may allow for dealing with some of these differences between software and vendors as well. So with all of that in mind, effort has really just recently been launched in order to establish a normative neuroimaging library. This is an effort that is supported by Cohen Veterans Bioscience, with the American College of Radiology taking a coordinating lead on the effort. It involves collaborations really on a tri-services level, and it involves academic sites both at the University of Virginia Health System and also the Baylor College of Medicine. Now, this normative neuroimaging library is a comprehensive effort that is designed to not only inform currently available FDA tools, but it's also designed to create a repository that's targeted towards representing the population demographic. It's going to utilize scanner harmonization along with neuropsychological assessments and medical screening to determine inclusion in the database. And it really addresses a current critical need for FDA-approved tools while addressing a rapidly evolving need for tools that will make their way into clinical care within the next 3 to 5 years. Now, the variables that are really going to be recruited towards are really sort of the top 3 that have been recognized to influence neuroimaging, and that is age, gender, and race and ethnicity. These other variables, although they've been recognized to influence imaging, will basically be tracked in order to get a more precise understanding for how these variables may influence variation across normal. And we'll be using US Census data in order to sort of inform how we recruit towards various metrics in this database, both for gender, age, and also ethnicity as well. In terms of numbers, this is really driven by a precision analysis that was done largely based upon diffusion tensor imaging to sort of understand where the point of diminishing returns was for precision. And so this was essentially an analysis that was performed to sort of understand at what point in number of samples do we sort of again reach a point of diminishing return for decreasing the variability that may occur more on sort of the technical level. And the final study design that was arrived upon was basically 500 subjects across age groups that span from 18 to 65. We'll implement the consensus recommendations of the 2014 ACR Montreal panel. And this initial data collection will include basically military sites at Lackland Air Force Base, San Antonio Military Medical Center, Baylor College of Medicine, and the University of Virginia. Now, in terms of applying normative neuroimaging data, again, as we discussed before, once we have a repository available, it will really serve as that canvas upon which at sort of an individual voxel level, we can make determination of variation from an established population-based normal. It'll also serve as a canvas for us to be able to start identifying patterns that are predictive of injury. And so we'll be able to train some of our algorithms with normal, so we can then basically bring appearances of abnormal into those algorithms and have the algorithms previously trained to normal. And all of this, at least in the setting of traumatic brain injury, will be designed to implement tools that will help us to understand in an individual patient, understanding the variability from one patient to the next. Does this patient have a traumatic brain injury? How severe is their injury? will they recover on their own, or do they need additional treatment? And essentially what we're working towards is the ability to be able to allow neuroimaging to have a greater role in traumatic brain injury for this very large group of patients who have mild TBI and concussion, for where neuroimaging presently has very, very little role. And so for mild TBI and concussion, to build the quantitative imaging platforms that are necessary to mine that information, and even in monitors severe traumatic brain injury, to allow for there to be additional information available to practitioners for that space between those grossly visible lesions, so we can have a better understanding for diagnosis and prognosis in those patients as well. And the goal really is for us to be able to essentially take our current view of neuroimaging from this sort of very high level approach to understanding what's occurring really more down at kind of the basic level in patients with this disease process. I just want to close here by acknowledging all of the members of the team here for this important initiative that's getting underway, both with the individuals here at the University of Virginia and within my laboratory, the group at Baylor, the group at the American College of Radiology, and our important clinical partners down at Lackland Air Force Base and San Antonio Military Medical Center, and really the vision of the group at Cohen Veterans Bioscience for recognizing the critical need for this resource and supporting the initiation of this effort. And with that, I'd be happy to take any questions.
Thank you very much, Dr. Stone. That was wonderful. I'm waiting to see if we have any questions. We'll give it a little time and we'll read them if we get any. So far we have no questions, just to let you know. We'll give it just a little bit longer to see if something comes in. Sometimes it takes a little while just for people to get their questions written. So I just want to give it a little more time.
Absolutely.
I'm not seeing any questions, so I just want to thank you very much for a wonderfully interesting presentation. And as you know, this will be on the website and on YouTube, so it is likely to get a lot of views following this. And if we do get any questions, we will forward them to you. In the meantime, thank you so much for your time.
Thanks for the opportunity.
Bye-bye.